Hello everyone, Dr. Kofi here again, and welcome to the TutorMed channel, where everything medicine is simplified. The standard 12-lead ECG does not have posterior leads to monitor the posterior wall of the heart. How then will the clinician be able to diagnose a posterior STEMI? This tutorial aims to address this topic, and I highly recommend that you watch our video on the ECG changes of STEMI before continuing with today's video if you have not seen that yet. The link to that video is in the description below. Kindly support this channel by hitting the subscription button and then the notification bell to be among the first to be updated on our new video uploads. Ready? Alright, let's get started. And so, like we saw in the lecture on the ECG criteria for STEMI, the standard 12-lead ECG has the following leads. We have the septal leads made up of V1, and some literature add V2, and then the anterior leads, which are V2, V3, V4. So V2 can serve as both a septal lead and an anterior lead. Then we have the inferior leads, which are leads 2, AVF, and lead 3. Then we have the lateral leads, which are leads 1, AVL, V5, and V6. Leads 1 and AVL are given a special name called high lateral leads because among the lateral leads, they look at the upper lateral wall of the heart compared to V5 and V6. Now it makes sense to look for ST elevations in the inferior leads if you are suspecting that the inferior wall of the myocardium is infarcted. Since there are no posterior leads in the 12-lead ECG, how will you tell that the posterior wall is not undergoing infarction? Well, you can opt to put posterior leads on the patient's posterior chest, and this will mean sacrificing 3 traditional leads, say V4, V5, V6, and putting them on the posterior chest to produce V7, V8, and V9. A cumbersome work, right? Now, to address this clinical problem, we need to revisit the concept of reciprocal leads. Remember, we said they are leads which face each other by virtue of their positions, and because they face each other, they kind of mirror each other. If you have been following our series so far, you'd realize that it is common knowledge that the inferior leads, which are leads 2, AVF, and lead 3, and then the high lateral leads, which are leads 1 and AVL, are reciprocal leads. Now, let's identify another pair of reciprocal leads. Anteroseptal leads, which is a combination of both the anterior and then the septal leads. So from V1 to V4, V1, V2, V3, and V4. And then the posterior leads are reciprocal leads, and so the anteroseptal leads and the posterior leads are reciprocal leads. Pretty straightforward to think that the anterior leads plus the leads that look at the septum should mirror the posterior myocardium, right? Great. And so the point here is that we can have a fair idea of what is happening in the posterior myocardium indirectly by examining the anteroseptal leads. Why? Because they are reciprocal leads. And so let's demonstrate this logically even before we look at the criteria. And so we have the posterior leads and the anterior lead, anteroseptal leads. So what you are saying is that whatever happens in the posterior leads, the anteroseptal lead will produce a mirror of that. That is the opposite of that. And so if we have ST elevation in the posterior leads, what do you think the anteroseptal lead would show us? Yes, you guessed right. It will show us the ST depression. if the posterior lead is showing an inverted T wave, the anteroseptal leads will show an upright T wave. Now, one other feature of ischemia is the presence of a pathological Q wave, particularly in STEMI. So the Q wave is the first negative wave in the QRS complex, and generally the Q wave is described as pathological if it is present in a lead where it is supposed to be absent, or when its presence in that lead is normal but it is deeper in length than it should be, and so pathological Q wave. If the posterior lead is producing a pathological Q wave, then the anteroseptal lead will produce a positive wave in the QRS complex, and that wave is an R wave, but this time this R wave is a pathological R wave. Alright guys, please don't forget to like and share this video and subscribe to our channel. And so the features that the posterior leads would pick in posterior STEMI, if they were placed there, would be or would include 1. ST segment elevation, which is the main thing we would see. There may be an inverted T wave and the presence of a pathological Q wave. So if we want to see this indirectly to diagnose posterior STEMI, we move straight to the anteroseptal leads, which are from V1 to V4. But the criteria says we should focus only on V1 to V3. And so the features we would see include an ST depression, that is an opposite of the ST elevation, but to be horizontal. Then an upright T wave, which is the opposite of an inverted T wave, if it is there. And then a tall, broad R wave, which is the opposite of the pathological Q wave. Bearing in mind that a broad or wide R wave is an R wave whose width is more than 1 millimeter or one small box wide. Remember, the QRS complex should be more than 3 millimeters to be considered broad, but this time we are looking at just the R wave in the complex. If it's more than one small box wide, it's a broad R wave. In addition, particularly in lead V2, there will be a dominant R wave evidenced by the R to S ratio more than 1. And so now, let's see this ECG of a hypothetical patient, say a 65-year-old African male known to have diabetes and hypertension and has a smoking pack here history of 36. He presented with a central and diffuse chest discomfort associated with anginal equivalents of nausea, diaphoresis, and left arm pain. Remember, we will have a full tutorial on ECG interpretation steps, but here we just want to identify ischemic changes. So this is a standard 12-lead ECG, of course without the posterior chest leads, and this is the rhythm strip, which is the entire length of lead 2. Let's begin by looking at the lateral leads, starting with the high laterals. So we have lead 1 and lead AVL. And as you can see, as far as ischemic changes are concerned, there is no ST segment changes or T wave changes, no pathological Q waves. And so the two leads are clear. Then we look at the other laterals, leads V5 and V6. And obviously, there are no ischemic changes. Then we turn our attention to the inferior leads, lead 2, lead 3, and AVF. Now lead 2 appears normal, but it appears leads 3 and AVF have some slight ST segment elevations. It appears the ST segment elevation is more than 1 millimeter above the baseline, and this is significant. And there are also 2 contiguous leads. In truth, it is possible to have an inferior MI with an extensive posterior wall involvement, and this can be explained by the blood supply of the heart, the right coronary artery giving rise to the posterior descending artery. But let's talk about this later in another video. For now, let's look at the anteroseptal leads. Lead V1, V2, V3, and V4. Now, V1 appears normal, but the rest are obviously abnormal, evidenced by ST segment depression in lead V2 to V4, as indicated. Apart from that, there are pathological or dominant R waves in V2 and then V3. I didn't mention V4 for a reason. And remember, even at all, the criteria has asked us to focus on V1 to V3. Then we have upright T waves in leads V2 and V3, also as indicated. And so if you put the posterior leads on this patient, you realize that this same patient would have ST elevations in V7, V8, and V9. And so adding this up, this shows that this patient has a posterior MI, evidenced by the changes we discussed, and probably has an inferior MI with a posterior wall involvement, if you will. And so, ladies and gentlemen of the TutorMed community, our take-home summary. The first point is that the standard 12-lead ECG has no posterior chest leads. And to diagnose a posterior STEMI, we examine its reciprocal leads, which are the anteroseptal leads from V1 to V4, but focusing on V1 to V3. When we examine these leads, the features expected are an ST segment depression, which is the opposite of ST segment elevation, upright T waves, which is the opposite of an inverted T wave, dominant or a pathological R wave, which is an opposite, or which is the opposite, I should have said, of a pathological Q wave, which the posterior leads may have recorded or may record, and then a dominant R wave in V2, evidenced by an R/S ratio more than 1. Thank you for watching, and see you in our next video. And please do not forget to subscribe to this channel, like this video, share this video. Bye.